logging into what is going to be the second AFS webinar webcast. And we're going to let a few more people hop on. And as we do so, before we really get started here, as people do log in, Phil, why don't you give us an update from New York? How are things in New York City these days?
Well, good evening, everybody. Thank you, Trip. It's quiet here right now. A lot of people wearing masks. In fact, everybody. We are slowly getting back to work, very slowly. Patients are reticent to come to hospitals in New York. But things are very, very quiet. We're going to probably start opening the city, I bet, in about a week and a half. A little bit behind the rest of the country. Mr. Cuomo is still loud and boisterous, but we're all knock wood healthy and ready to get back to work.
Very good. Well, we'll go ahead and get started. So like I said, this is the second of a series of webinars hosted by the American Foregut Society. Should certainly thank Kate, who has been instrumental in keeping us all corralled and organized, and certainly the brains and beauty behind this operation as well. Tonight we're going to talk about GERD and options. We are lucky to have on our board of directors Phil Katz, who is sort of my GI dyad, or I'm his surgeon dyad at the AFS on the membership committee. And Dr. Katz, especially for the GIs, but for most, is well known in the field. Really needs no introduction, but he's at Cornell Medical School. As you can see, he's the head of the GI Function Laboratory. And he has hundreds of publications, over 120 publications, many of which deal with esophageal motility, as well as sort of pharmacokinetics, and then of PPIs, as well as appropriate use of PPIs. And so I think this is a perfect topic for him to tackle this evening. Take it away, Phil.
Thank you, Trip. Thank you, Kate Freeman. Thanks to the AFS. For all of you who are taking time out of your schedules to listen to me tonight, I appreciate it. I hope it is valuable. I hope you learn something, and I hope you will be stimulated enough to ask questions.
I'm going to interrupt you right out of the gate. I failed to mention that if you do have questions, please hit the Q&A tab. Should be on the lower right portion of your screen, and then I will take those questions in, and then we'll have some time at the end for discussion. If I think a question is a burning one, I will be happy to interrupt Phil once again.
All right, so my final comment was to remind everybody that the principles of the AFS and the society is a collaboration between surgery and gastroenterology. The format of this lecture hopefully will cover parts of both sides of refractory GERD, and as I said, be valuable to you in your clinical life, research life, or both. You already heard from me about New York. This is a very, very, very interesting time for all of us. And as we get back to work, those of you who are in Foregut will be seeing patients with refractory GERD. And as of today and going forward, when I think about refractory GERD, when it's written about, when it's discussed among groups, its definition is not precise, but we use this working definition that a PPI at some dose is not controlling symptoms. Kate, if you let me do this one, is this doing automatic? Because I didn't push the button, I hope not. So refractory GERD presents in two forms. Scenario one is someone who has objectively documented GERD, either by erosive esophagitis and or abnormal esophageal acid exposure. on a prolonged pH monitoring study, but unpleasant symptoms remain despite being on a PPI. And then scenario 2, which is probably more common in GI, is that a patient with symptoms suspected due to GERD has been treated empirically with a PPI, but the symptoms have not been relieved to their satisfaction. Now, which one of these scenarios dominate is in part dependent on your practice and will in part dictate the approach to that patient. So objective GERD, not being relieved with medication, or someone who's been empirically treated for suspected GERD and they have residual symptoms despite the drug. In either case, the key question is the same. Are the residual symptoms due to GERD? And if so, can we determine why? And I will review that. So in thinking about this topic, as I have discussed it over the past several weeks in some venues, is what has changed in the approach to refractory GERD since we wrote the 2013 ACG guidelines? Actually, a bunch. So we know that PPI adverse events have now received a tremendous amount of press, publicity, literature, and that regardless of where you stand on the veracity of those PPI adverse events, they have mandated that we think carefully about new options for GERD because patients have demanded them and have asked about them. We now have level 1 evidence for the effectiveness of Nissen fundoplication in refractory GERD, for magnetic sphincter augmentation or links, and TIF success, all in patients who have residual symptoms despite being on a PPI. We actually have outcomes data on one of the algorithmic approaches to treating patients with refractory GERD, which I will show you is optimizing a PPI. We've had, unfortunately, no major advance in medical therapy, although there are a couple of tweaks that I will throw out there for you. And we do have a greater understanding of the reasons for incomplete response to medical therapy. So all of this has resulted in a shift towards an increased use of objective diagnostic testing, which is the way I will try and wrap around this to finish the talk. So let's talk first about transoral fundoplication, or TIF. For this audience, I'm not going to go into details about this endoscopic procedure that allows us to create what is tantamount to a 270-degree wrap without repair of a hiatal hernia. The core of TIF comes from this randomized controlled trial looking at refractory regurgitation, published by John Hunter and colleagues in gastroenterology in 2015. This was a study looking at patients who had incomplete relief on a PPI, predominantly troublesome regurgitation, which was defined by a rigorous survey definition. They had all were endoscoped, had high resolution manometry, a pH study, and were included if they had hiatal hernias less than 2 centimeters, only measured in one way by endoscopy. They had erosive esophagitis less than grade C, so A or B, and normal high resolution manometry, and an abnormal pH monitoring study based on abnormal acid exposure. This was a study that randomized patients to TIF versus sham TIF. Everyone got a proton pump inhibitor for 2 weeks after the TIF, and then they were compared after being randomized to 2 groups, TIF and concomitant PPI placebo, or the sham group got a PPI once a day, which could be increased to twice a day at 12 weeks for incomplete responders, and then the patients were evaluated at 6 months. They used an intention to treat and a per protocol analysis. They were actually quite similar. Remembering that the primary outcome was relief of troublesome regurgitation. That's the only outcome I'm going to address in the formal part of the talk. At 6 months, 58 of 87 in the TIF placebo arm compared to 19 of 42 in the sham PPI arm, which is statistically significant, showed an improvement favoring TIF. The protocol analysis, as you can see looking at the slide, shows remarkably similar results. So whether you allow dropouts or whether you include dropouts, the results show a statistical significance at a p less than 0.02 level. If you're a number needed to treat person, it comes out to about 8. Now, pH normalization is a standard that procedures are held to, perhaps in some way unnecessarily, because improvement in esophageal acid exposure may be sufficient to make many people well. In this case, this is a meta-analysis published in 2018. You'll recognize several of the authors. What this article showed, using this petagram as an example, with the diamond at the bottom, that at that point, when you pooled all of the TIF studies that had looked at pH control after the operation, there were a fair number in which it was quite clear, including the overlaps. The diamond favors TIF. If you look carefully at these numbers, there was some substantial refluxes here, and improvement was the norm. So improvement in pH control, improvement in regurgitation, the first high-level randomized control sham trial. Now this is follow-up data. This is follow-up data published in 2018, 5-year follow-up of a reasonable sized cohort, 44 patients followed out to 5 years. Again, elimination of troublesome regurgitation on the y-axis, a substantial proportion of patients who have their regurgitation, in this case, eliminated. And then this 10-year single center observational cohort study, no controls, small number, is very instructive for a clinician. And I'm going to walk you through the slide. So if you want to look at this positively, okay, no PPI, halved PPI, back on PPI, needed a Nissen, or had complications. So for no PPI or halve their PPI, close to 75% at 10 years, small numbers. 2 years, 78%. So you can expect some recidivism, but overall, that's a reasonable outcome. And it's fair to tell a patient that they have a chance to discontinue and a chance to reduce. And for people who don't want to have a traditional operation, I don't think that's a terribly bad outcome. Very low level of complications early, not quite clear from the manuscript what all these complications were, and probably about 10% went on to need a fundoplication, and then a small cohort were back on PPIs. So if you look at this carefully, you may have about 15%, 14%, somewhere in there who probably did not end up with a satisfactory result. But overall, a quite interesting 10-year follow-up, which we would like to see more of. Now, magnetic sphincter augmentation of links, again, not necessary to go into great detail with this group. A ringed magnet is sized and implanted laparoscopically around the esophagus with repair of a hiatal hernia is now the standard. This is the seminal study looking at comparing magnetic sphincter augmentation to twice daily PPI for symptomatic refractory regurgitation in patients who were on a once-a-day PPI. This was a randomized multi-center trial Patients had to be refractory to once daily PPI with moderate to severe regurgitation. They had to have an abnormal pH study, a normal HRM, and then were randomized to magnetic sphincter augmentation performed laparoscopically or a PPI twice a day in a 2-to-1 randomized study with a crossover as things evolved for those that did not do well. And this graph is basically the key result. So we have magnetic sphincter augmentation on the left, BID PPI on the right, where the arrow is, no regurgitation in the light blue or gray, the beige or whatever heck color that is, and then the magenta or the dark red, moderate to severe regurgitation, a small number after magnetic sphincter augmentation, a substantial number on a PPI. PPIs control acid, still remain with some volume, and in this case, in a randomized control fashion, surgery was superior to high-dose PPI for refractory regurg. This looks at symptom improvement, GERD HRQL, and discontinuation of PPIs with the Lynx device compared to BID PPI. Again, this is from Reg and the group study published in GIE, and you see a substantial advantage for the operative intervention in this trial. pH control is, again, instructive, very instructive. So if you look at pH, the traditional way that a gastroenterologist would look at a pH study, time pH less than 4, again, favors surgery. But here is the PPI group with 75% normalizing their pH control, likely healing their erosive esophagitis and eliminating their heartburn, but not necessarily their volume. The Meester score, similar numbers, and then looking just at reflux episodes, as you might expect, that an operative intervention should do much better at eliminating reflux episodes than a medical therapy. But again, there is some elimination with a PPI. So PPIs reduce reflux, not to the same extent as magnetic sphincter augmentation in this study. And now a seminal trial published by Stu Speckler and colleagues. Once again, a paper for Speckler in the New England Journal. An incredibly difficult study to perform at multiple VA sites. And I'm going to walk you through this slowly because it's very important, if you don't read this study in detail, to understand what they did. Okay, so you had to come to a GI clinic for heartburn, in this case, refractory to PPI. You had an HRQL. If you were verified by HRQL score to have bothersome heartburn, you got put on a 2-week trial of omeprazole, 20 milligrams twice a day, to take medication actually 30 minutes before breakfast and dinner. There's actually a typo in the New England Journal. If you still had bothersome heartburn, then you went into the trial, okay? So you got thrown out if you got better on your 2-week PPI trial, your optimization trial. If you had an endoscopy with grade C or with less than grade C, normal manometry, and an abnormal impedance study, and the surgeon thought that you were a good candidate, then you were potentially in the trial, okay? So A or B, normal manometry, and a pH study showing abnormal acid reflux or a positive SAP for heartburn. Okay, and then you got randomized to a laparoscopic Nissen fundoplication, PPI plus baclofen and a tricyclic in order, or PPI plus placebo baclofen and placebo deciprabine tricyclic. 366 patients were enrolled. Now you got to think about this when you're taking care of refractory GERD, okay? So 70 just didn't play. 54 got excluded because they couldn't complete 2 weeks of omeprazole. They wouldn't tolerate manometry, and the surgeon rejected them as too sick to operate. 42 out of 366, or 42 out of the residual after 125 were eliminated, had PPI responsive GERD during their 2-week omeprazole trial. Very important for both sides of the fence here, surgeons and gastroenterologists. It's important to optimize the drug. You got to do a good endoscopy, EOE, other endoscopic abnormalities, and then 7 had manometric abnormalities that were sufficient to exclude them from being operated on, which was predominantly achalasia or severe ineffective motility. And then 99 out of the group had functional heartburn, meant that every study was negative. So ultimately, 78 people got randomized. And what they found would not have surprised any of us, but nevertheless, they were able to prove that a niacin fundoplication was superior to additional baclofen or a tricyclic versus continued PPI plus placebo, kind of in a stair-stepped order, remembering that not everyone got well. So here's refractory GERD, carefully worked up, good outcome with surgery, but imperfect. Now, let's move on to proton pump inhibitors, why they might fail, okay? Dose timing relative to food, we already talked about this. The dose is insufficient. It's very rare to see a hypersecretor, and PPI resistance has never been documented in the literature. Genetic variability is interesting. It's nice. It's sexy to think about. But in reality, it's very hard to measure, and it's very, very expensive to measure. And it's very hard to know whether it really means anything in the big picture. If you're worried about genetic variability, rabeprazole is one molecule, very, very well used in Japan, that tends to ignore CYP genetic variability, but I think in real life it doesn't matter. Now, one of the most important things to remember is that PPIs are better for some things than others. And in this case, I'm going to go from the bottom up. So when you deal with chronic cough and hoarseness, and you think that it might be due to reflux, beware, beware, beware. PPI trials are fine, but it's very hard to design a trial with the right objective data to show that PPIs are better than placebo. Keep that in mind as you think about doing surgery in that group. Chest pain, an interesting phenomenon. If you are pH positive or you have erosive esophagitis, then the PPI is quite superior to a placebo. If you're pH negative, normal endoscopy, not likely to occur. This suggests to me that these patients should not be empirically treated, but should be worked up, arguable. PPIs and regurgitation, we've already talked about. Heartburn relief, clearly superior, and healing of erosive esophagitis, substantial improvement with PPI compared to placebo. So acid makes injury, acid makes heartburn, acid probably makes chest pain. Everything else, not all acid. Be careful, be thoughtful. Now, when you take the PPI, might make a difference. This is a pH study that we did long time ago, 1998, a very small N, looking at a omeprazole before breakfast, before dinner, and a split dose of omeprazole before breakfast and dinner, looking at pH control in the stomach, and the double dose PPI before breakfast and dinner was superior to 40 milligrams before breakfast and 40 milligrams before dinner, which was better than before breakfast. So first meal of the day may be the easiest, therefore compliance better. But if your patients can remember to take it before dinner, probably a potential better outcome than in the morning. Non-acid reflux episodes do cause symptoms. That was evident from the randomized MSA trial, but this was a proof of concept study that we did in 2001, looking at heartburn, acid taste, and regurgitation, combining impedance in gray for, combining impedance with pH, showing symptoms with acid and non-acid reflux. More likely to have heartburn be an acid phenomenon. Regurgitation seemed to split, but both acid and non-acid reflux cause symptoms. Now, I've already showed you the specular trial. I'll show it to you again very briefly. This is another randomized trial looking at optimal omeprazole dosing and symptom control. Not a very tough acronym when you look backwards, also not very sexy. A small number of people with continued heartburn on BID omeprazole not taking optimally by history. They were randomized to optimal dosing or continued as they were doing, and there was a decrease in frequency, severity of symptoms on the optimal regimen compared to leaving people alone. So if you pay attention and the patient pays attention, you've got an opportunity, if they want to keep taking the PPI, to gain optimization. And as I had outlined in the original study, here are 42 patients who had PPI responsive GERD with a 2-week omeprazole trial taken optimally. 42 out of the original 466. Again, if we kick out the 125 that got excluded early, it's it's 42 out of about 240. That's not a bad ratio for simply telling the patient to optimize their drug. Now, as you think about these patients, and I ask you all to continue thinking about why people are refractory, it will help make decisions about treatment. So acid reflux, weakly acidic reflux, and perhaps bile. We've talked about acid. We've talked about weakly or non-acidic material. You can't measure bile today. There's no Billy Tech around. The presence of bile in the stomach will not do it. But it's possible that multiple factors are involved. Postprandial reflux, upright reflux, nocturnal reflux, all may reflect differently on symptoms and injury. Postprandial reflux in particular, where impedance may help. The severity of mucosal disease, grade D does not heal as well as grade B and A. Grade C similarly. Non-erosive reflux disease is a black box, poorly responsive to PPIs compared to erosive esophagitis in the literature. Be careful to evaluate them well. People with motility abnormalities do pose some element of quote risk. You can argue with me about that if you like, but remember that many and most, in fact, of the trials that are well done with TIF and MSA have excluded people with abnormal motility. And although the word on the street suggests that it might be okay in certain circumstances, I think you got to be careful. We've talked about volume. We've not discussed paraesophageal hernias, big hernias, but mechanical issues are crucial. And then there's going to be an occasional patient with a gastric emptying disorder that may be partially responsible for their refractory GERD. There is a difference in esophageal sensitivity between men and women across people. There are a fair number of people with either acid sensitivity to normal amounts of reflux or a coexistent functional syndrome unrelated to the esophagus, and they need to be sorted out because they will not respond to a mechanical intervention. So finally, You got continued reflux. Your PPIs are optimized. There's no alternative diagnosis. The patient says, I don't want an operation. I don't want a TIF. I don't want anything else. What can you do? Now, baclofen will reduce reflux episodes. Not much more do you get from that. Prokinetics will improve gastric emptying. There isn't anything really good, and there's no data with procalipride. The data with metoclopramide and the side effect profile are difficult. Gaviscon is an interesting drug. The United Kingdom Gaviscon seems to be more effective than the one we make in this country, but the one from the UK has never been brought here, and I could not totally figure that out if it was so good. But every once in a while, you can pop Gaviscon as a postprandial issue or occasionally at bedtime, and because of the floating raft, it might help. And then finally, tricyclic agents, because they reduce sensitivity, probably are better for functional heartburn than the sensitive esophagus. All of these are tried by people. I advise not using any of them empirically because of the potential side effect profile. Now, baclofen in proof of concept, again, is excellent. Marcelo Vela, when he was with Don Castell and I back at Graduate Hospital many years ago now, when I had a definitely different color hair, did a very nice study showing that baclofen could reduce acid, non-acid, and total reflux episodes. It's a good anti-reflux drug. Side effects really preclude that it works. Now, there are two drugs in clinical trial. A letter drug made by Ironwood that's a bile acid sequestrant that has been engineered so that it's delivered very nicely in delayed fashion. Excellent phase 2 data showing improved regurgitation and heartburn in patients refractory to once-a-day PPI. It's now in delayed phase 3 trials because of COVID, but it's moving. And then vonoprazan or vonoprazan, but vonoprazan is a potassium competitive acid blocker, or PCAB, the first available in the world in Japan, a super acid inhibitor, very rapid onset, very rapid offset, potentially a very flexible drug that is now in US trials and is in the middle of phase 3. I think you can expect this one probably 2022. This one, maybe 2022, but it's a little harder trial to enroll. So perhaps more medical therapy coming relatively soon in our work life. And then remember, some people just simply don't have GERD. Here are people with functional heartburn in reasonable numbers in patients who are fully worked up for other relationships of reflux to symptoms. Ultimately here, patients with functional heartburn. So at the end of the day, if you don't have GERD, you look for rumination, you look for aerophagia, you do a good manometry looking for achalasia or a severe motility disorder. You think about gastroparesis, but please don't do gastric emptying studies unless people are symptomatic. And if you must look for EOE, you might as well, because even Speckler found some in that VA population. So to conclude, what I hope has been an informative talk, an abnormality or alteration in any of these features could be responsible in all or part for failure. GERD may not be the cause of residual symptoms, so think about other alternatives. Or perhaps the residual symptoms are functional. There is a lovely algorithm in this article by Prakash Gaiwali and a group from the Lyon Consensus that tries to look at the technology that we have and look at objective diagnosis of GERD. And what it does is look at the procedure and stratifies by conclusive, borderline, or inconclusive, what you can do to support what the other studies don't show you, and then evidence against. And while pH is not necessarily the gold standard, ultimately a normal pH study with esophageal acid exposure less than 4% or a Demeester score less than 14 with very few reflux episodes is really the way you kill this diagnosis. C or D, long segment Barrett's and a stricture clinches it. There are normals who have grade B, so this consensus group said beware. I'm not in complete agreement, even though I think I might have signed on to that. And then you can get some help with histology or mucosal impedance, which we can talk about if people have questions about it. The consensus group felt that using a cutoff of esophageal acid exposure of greater than 6% would give people a margin for error because of variability in normal studies across the board. There's no good translation of the composite score to greater than 6%, but if you wanted to jump it up to 18 to feel better, that would probably be where it would go. And then you have these adjunctive things on high resolution manometer. So, Dr. Buckley, since nobody's interrupted me, ultimately medically refractory GERD is likely due to abnormal reflux control, a mechanical or motility feature, or that the symptoms may not be due to GERD. So there are two algorithms that I will close with. Scenario number 2, the patient empirically treated without an objective workup. Optimize the PPI. If you don't have adequate symptom relief, take them off the PPI and do a diagnostic EGD. If it's abnormal, then you're going to make a diagnosis one way or the other. If they've got erosive esophagitis or Barrett's, you confirm GERD. If their EGD is normal, by all means do a reflux monitoring study while they're off PPI. With calibration-free Bravo, you should be able to do that at the same sitting. If they have symptom relief, you can probably hang on without a workup early, but remember, everybody should get a chance to come off PPIs and have a discussion of long-term management options that don't involve medicine. If you've had objectively defined GERD, esophagitis grade B, C, or D, or an abnormal pH monitoring, you've optimized your PPI, you have symptom relief, then you go back into that algorithm and you talk about long-term options. If you have unsatisfactory symptom relief and the primary symptom is regurgitation, and you've had previous objectively defined GERD, I don't believe you need to go for any further workup, and you can consider an intervention at that time. If the patient is hesitant or they choose not to, you can come back and you can perform impedance pH monitoring on a PPI. I would do this probably for heartburn, although many would say I wouldn't have to. I would do it for chest pain, and I would definitely do it for any atypical symptom. If it's normal, do an HRM, continue the PPI, and treat for whatever else you find. If it's abnormal, then you're either going to super increase the PPI, double the dose, or more than likely you're going to think about surgery or an endoscopic intervention. So with that, we have plenty of time for questions. I do thank you very much for listening. Hopefully, we won't have to be given these lectures at night except because we want to, and not because we're not working. So thank you, everybody. Trip, back to you.
Thanks, Phil. My gosh, you so elegantly summed up, I think, as you said, what embodies the AFS, which is I feel like surgeons should really understand and optimize the use of PPIs when appropriate. And then we hope that our GI colleagues also understand the surgical or interventional options and can speak to them well. And you did that beautifully over the last 35, 40 minutes. I do have a question from Dr. Friedman. She's actually a colleague of mine in the Austin area. She's a gastroenterologist. And her question is, if after the first evaluation, long segment Barrett's with high-grade dysplasia and doing another, and I'm not entirely sure I understand, to better evaluate on higher dose therapy in a couple of weeks, what is the timing for a laparoscopic procedure for a 5 to 6 centimeter hiatal hernia before or after complete ablation or after initial ablation?
So if I can subtext that question, when would I operate on somebody who needed RFA?
Yeah, I think we've got long segment Barrett's had high-grade dysplasia and probably needed RFAs. They've got a big structural defect. What's your strategy going to be for that?
I'll give you the short practical answer, and then one that might be a little bit more erudite, and then I'll yield to my colleague for his response. I think in a perfect world, if you can get a complete ablation and then keep it with an operation, that would be the ideal scenario. Everyone knows that long segments are harder to do everything with than short segments. If you are hesitant to believe that you can get adequate reflux control, which is crucial to maintenance of RFA and probably getting CRIM, I could accept doing an operation prior. I just feel better getting it ablated first and then making a definitive decision about how things are going to get maintained.
Yeah, I agree with that. I would probably, and I'm sure you would too, I'd try to really assess what the patient's symptoms are. Are they significantly symptomatic from a regurgitation standpoint, from their hiatal hernia? Are they having, chest pain type episodes? But I would prefer to at least get them going on the ablation. Of course, ablation is only really effective if you can control reflux, and so that can be with PPIs or surgery, and then they're going to end up going to surgery anyway. So I would try the medical therapy first. Hope that answers your question. Let's see. Second question: how do you manage those with IEM and intraesophageal reflux with symptoms of regurgitation, no abnormal acid reflux on pH monitoring?
Wow. That's a rare one.
Put them in the functional category.
Well, that's a very tricky lesion, and it's quite an intelligent question, actually, because I don't have a data-based answer. So I think there are a few people in the world who have primary ineffective motility, whether it's due in part to a secondary cause, whether it's in part due to an evolving motility abnormality. I always carefully study them. I do endoflip, look at their EGJ, see if there's any element of an EGJ outflow obstruction. If I think that it is, I'll either do a barium swallow, making sure that I do a timed swallow. And if I think that there is an EGJ outflow obstruction that I missed at manometry, then I'll treat that. If I'm left with IEM, and I truly believe my pH study is indeed normal, occasionally I'll use some bethanechol. I've been trying to experiment with prucalopride. I must admit I haven't had much success in people who aren't constipated at the same time, because they all seem to get diarrhea. I have passed a dilator on some of those patients, not knowing why in the hell I would, but I have in the past. Perhaps they had EGJ outflow obstructions that were mild and I couldn't detect them by old-time methods. And I do use a fair amount of tricyclic, hoping that it's predominantly sensitivity to slow bolus movement, and then I won't slow things down so much that the imipramine or the amitriptyline might help. So a lot of reassurance, a careful workup, and then a menu.
I think I wouldn't add to that other than say, you know, this is a rare subgroup. There are several rare subgroups, and I think that, as you just said, they benefit from a extremely careful workup, an extended workup, where you can do endo flip. You have someone intelligently adding on additional medications, not throwing the entire kitchen sink at one time, and or blowing them off as functional. But I think that's great. Another question from a thoracic surgeon saying, how do you choose PPI? It seems everyone just gets Dexilant if unresponsive to omeprazole. Do you have any comments on PPI choice and when you go from single dose to maybe double dose? Of course, there's some, you discussed the trial looking at single dose, people refractory to single dose, going to double dose omeprazole versus links. But how do you choose your PPI?
So around here, people usually get what is least expensive as their first hit. For the first go around, I would be a fool to tell you that there was really a major difference, and I wouldn't really think about it. There are a couple of caveats that I would throw out there for you to just keep in your brain. If you just look at the number of hours of the day in which PPIs control pH, meaning get it above 4 in the stomach, esomeprazole is superior to lansoprazole and omeprazole, and probably to rabeprazole. Never been compared to Dexilant, but Dex has probably got a little better acid control. So if you're going to switch PPIs, or you want to use the one that has the quote unquote best intragastric pH control, you'd have to argue for Dexilant, dexlansoprazole or esomeprazole. But ultimately, there really is no good choice of one over the other. I often switch to rabeprazole simply because very few people use it. The patients don't recognize it, and they don't have to tell me that they already took it. Twice a day PPI, omeprazole, esomeprazole, rabeprazole, they're probably identical. Both a little better than lansoprazole or pantoprazole in the test tube. And there just isn't any data with double dose Dexilant in the world that I know of. So if you use it, you use it. But that's probably too much information. Bottom line, probably doesn't matter if they take it right. I never switch more than once. And I usually use double dose before I quit. But that's even changing for us as we become more familiar with outcomes from MSA and TIF.
So,
excuse me.
It's one of the many reasons why I love you, Phil, is that you're a long format guy with thoughtful answers. So if just give me an off the cuff answer. If I go from single dose to double dose anything, what do you think the therapeutic gain is? If I'm asking you as a patient, like, okay, let's just say I have to pay out of pocket for my Dexilant. Some clown wants to put me on double dose Dexilant. What's my expected therapeutic gain, Doc?
15%.
15%. And I think you said something important there, which is not to keep bouncing around, because a lot of times I think we surgeons anyway see that these patients have been on multiple PPIs, and they say that they're, nothing works for them, and but they can name off every single one they've been on, which is, kind of a cartwheel of medication that they've been pounded with. So anyway, great question and great answer. I'll continue on with the Q&A, but Reg wanted me to ask, how long do you have to be off PPIs for endoscopy to reliably show esophagitis? I feel like this is, I think somebody you might mention did this study. I can't even imagine how it got to an IRB, but reliably show esophagitis, and what current guidelines recommend EGD off PPIs, and how well are they followed?
The little data in the literature
You're suffering there, Phil.
prospectively come from Kerry Dunbar and Stu Speckler, and it's a VA study, and they had them off for a very short time, a couple of weeks, and they were actually able to get people to relapse to grade C. That's a rather unusual population of men who probably smoke without malice or bias. There are plenty of maintenance studies that show relapse really is a continuum that probably begins in the first month and then continues out to 6 months where it reaches a maximum. We're going to try and sell 2 to 4 weeks in the next GERD guidelines, but we haven't had that accepted yet. And there's no current guideline at the present time that really addresses taking people off PPIs to endoscope them. The guidelines that I'm familiar with recommend endoscopy for people who are not responding, or for initial diagnosis in certain subsets, but there's no standard recommendation for how long or specifically to stop. And I guess if there was one, they wouldn't be well followed.
Okay, we're going to go super short format because I didn't realize how many questions we have here. So
okay, so we'll hustle. Okay,
we'll
go.
Hustle. Adding an H2 blocker in the nighttime to single dose or double dose PPIs, yes, no, maybe.
You can if you want to, and it seems less needed today with other options, but feel free.
Feel free. What do you think about Carefate? How do you use it, and in what form do you use it? I'm just going to say up front that you shouldn't use it in the presence of PPIs because it requires acid to work the way it was designed anyway, but you can comment on that. But do you use slurry pills?
I don't use it at all except for pill induced, and in people who absolutely push me to give them something beyond a PPI. And I usually use a slurry.
I use it for, at least if I scope someone with achalasia and there's a stasis, I mean, I use it in that situation. Do you ever use it for that? I know we're talking about GERD and not achalasia, but
I'll use it, like a real doctor for, somebody I want to try and deal with functional disease, and I don't know how else to treat them. There'll be occasional somebody with a big ulcer in their esophagus post something that I'll put on a PPI plus for a couple of weeks. Sometimes potentially for a marginal ulcer. I mean, but in real life, I don't prescribe it for GERD.
Okay. In real life.
Except in pregnant people.
Okay.
And they're all women, so pregnant women.
Very good. Watts biopsies are starting to return results of non-goblet intestinal metaplasia. Do you have any surveillance recommendations for this type of lesion? I certainly have an answer here, but go for it.
No, I don't. Cryptdysplasia, maybe. I don't know what non-goblet cell IM means in the U.S., and I don't particularly think it's a good thing.
Yeah, so this is maybe a question for our next seminar, which I'll just go ahead and give a plug for. I think I will be one of the discussants and joined by Dan Lister and Mike Smith, also of New York. And we're going to be discussing Barrett's esophagus next month. So we will hit that. I mean, basically non-goblet intestinal metaplasia. Either you didn't find the goblets, you were too far down, you weren't up by the squamocolumnar junction, or they don't have Barrett's. So maybe, I don't think there are any surveillance recommendations for that type of lesion would be my quick and dirty answer. Mimi Cantu, first of all, gives you props for a super talk, Phil, so way to go. Can you clarify your summary algorithm? Would you not do HRM or endoflip to assess motility in a pH positive refractory GERD heading for surgery, particularly regurgitation phenotype?
I'd always do some sort of motility evaluation before surgery. The algorithm is meant to be diagnostic. So I didn't want to imply that I would just do an operation in someone with unsatisfactory symptom relief without a full manometry workup. So I'm sorry if that was not clear, but it was meant to think about an approach to the GERD portion. So it assumes that I would do manometry or I'm not going to comment on FLIP in great detail. I think it's too soon to use FLIP as your final arbiter of pre-fundoplication without data.
Yeah, I certainly agree with that. But
I think it probably will work, but I think we need data first.
yeah, you gotta understand your esophageal function. So I always say it's about getting objective evidence of GERD, understanding your esophageal function and what structural abnormality or lack of abnormality you've got. All right. What do you do for a patient, or what do you recommend for a patient who has a very low pressure esophagus, normal LES pressure, a DCI of 450, and an IRP of 13? I'm not sure I understand the question exactly, but I thought I'd throw it out there.
IRP is 13.
So that's,
The DCI is 450.
DCI 450. So
and what's the low
IRP?
What's the low pressure? You're talking about the distensibility index that's low?
I don't know exactly. I'm not sure. And just because I couldn't exactly understand that question, we have three from the same physician. So I'll just go to another one of his. It seems that he says, why don't you perform 24-hour pH impedance for the non-acid reflux?
I will perform impedance pH to look for non-acid reflux in almost everybody who has unsatisfactory symptom relief to PPIs. If they've had objectively documented GERD, for sure. For the most part these days, if someone has never been worked up, we're doing an off-therapy monitoring study, whether it's done with a catheter or whether it's done with a Bravo, depends on the person and the time. The ticklish part about impedance is how well it's accepted, how well it's analyzed, and ultimately how important it is for someone who had a previous diagnosis of grade C erosive esophagitis and who's not responded to a PPI. if your bias is that they have reason to have an operation to begin with, they got GERD, then I don't know if the impedance pH study provides you enough arbitration to go one way or the other. But that's a dealer's choice. If your bias is that you'll only operate or do TIF on someone who has abnormal acid exposure or non-acid reflux despite a high dose PPI, I think that's your privilege. But the data would speak today that that's not necessary. So I use it a lot, and there are just some occasions where I don't think you have to do on-therapy monitoring before you operate.
So let's throw another one at you. Do you observe any improvement in manometry results after anti-reflux surgeries for patients with abnormal manometry, like an increase in peristalsis or DCI?
The data are conflicting and hasn't been studied in a long time. So yes in some, no in others, and that's it.
I'm gonna maybe just
Game
throw
time.
out there. I tell patients with diminished motility that there have been studies that show, as you said, I think the data are conflicting, but in favor of improved esophageal motility after anti-reflux surgery, to the degree that significant reflux decreases their esophageal motility. So it's an unknown, but it's probably ways towards improved motility. Would you agree with that, or would you?
Yep.
Different way of saying kind of what you said, but I guess I take a more positive take on it. So I'm going to throw out a scenario. We've got a 40-year-old gal. I'm hearing. Oh, you got to go. You got to go, Phil.
I'd like to wrap it up in
Let's
a
wrap
little
it up.
bit.
That's okay.
Yep.
I think we got to most of the questions, and I was almost ready to give you a long format answer session. So I was going to really throw you a zinger, but
Well, go ahead. I'll take one zinger.
No, it's okay. It's okay. Let's go ahead and wrap it up to respect everybody else's time. Phil, thank you so much for being generous with your time tonight. Again, a world leader and thoughtful leader in GERD and our approaches to it, both from a medical and procedural / surgical management. I think that we all have a lot to learn from each other, both on the surgery and medicine sides of the fence. And I think continued collaboration through AFS is the way to get to the best outcomes for our patients. So thank you so much. Thank you for everyone. I saw that we had, I think, up to 70 participants or maybe more at one point. So thank you again. Thank you for your questions.
Trip, if you want to send me the unanswered questions,